Thanks very much, Devin. So as Devin said, my name's Lynn Stevenson, but I thought that when you moderate something like this, you should have more than a passing familiarity about what you're doing. So I did my homework, like all of you would do, and went on to You and the AI, spent a lot of the time on that. But then I went to the old chat GPT, and I said, so, gee, could you help me with an introduction? And not only the introduction, could you help me with making a little bit pizzazz? So I'm going to tell you what came back. Hello, everyone. I hope you enjoyed your lunch. And my name is Stephen Lewis. And I thought, wow. And they said, but not to be confused with the Stephen Lewis from Africa and HIV. So for all intents and purposes, I'm Stephen Lewis. So I just thought I would mention that if you were wondering, where is he? Apparently, I'm him. The hint and tip also was when you introduce yourself, you should do it with some flair or some pizzazz. And then I'd put some demographics in, which was an error. And they said, and we would suggest a woman of your vintage, don't you love that? Perhaps shouldn't bound up the stairs. And when I saw Adrian do that to say, I thought, well, he's kind of vintage. Anyhow, I'm a eternal optimist, and so vintage is in. So I want you to know I took that. See, you agreed, don't you? So I'm vintage, and I'm Stephen Lewis if you would prefer. But actually, I am Lynn Stevenson, and I'm very pleased to be here. I'm very empathetic to our colleagues here on the stage because I've been part of the debate, so I understand what it's all about. So you know, those of you that are of a particular generation, so I always say with apologies to Generation LMNOP, who have never heard of the CBC and have never heard of a radio, that actually The Debaters is a program on the Canadian Broadcasting, and people like me actually have a radio and we listen to it. So it follows the same kind of format. But for those of you that have never heard of it, I will explain the rules. So what we typically do is we enlist experts, clearly not me, in a particular subject matter. And I think the important thing for all of you to know, and we assign the sides they're on. So that they're either the affirmative or the negative, and it doesn't necessarily mean that's what they would say if they were somewhere else. And that came about on the second year of when we had the debate, and I was working for government, and there's always a disclaimer. Like, you can never say anything unless you're having a disclaimer. So when you're puzzled about the introductions, why is so-and-so saying yes or no? It's because they're assigned. So the topic today is, be it resolved that artificial intelligence is the key to solving our HR crisis. And I think all of you will be interested in the perspectives that they bring to bear around that. So arguing for, on my right here, is Sam Garby. He's an internal medicine specialist at VGH and co-founder of Era Health, which uses AI to enhance health record keeping. And to his immediate right is Shannon Malkovich, who's the Executive Vice President, Provincial Digital Health and Information Services for PHSA. On my left is Deepak Kora, Chief Founder and Chief of Production Vision and Partnership with Synthesis Health, Inc., an AI medical imaging company, and he's actually lives in Calgary, and he's a pediatric radiologist. And to his left is Michael Byrne, who's founder and chairman of Santis Fe, Health, an AI medicine company, and he's a gastroenterologist from Vancouver General, who's also a clinical professor of medicine at UBC. So we've kind of got an internal medicine thing happening. I'm not sure what that's all about. So there's a couple of rules around the debate. The first rule is it's a non-contact sport. So there's no, you can't move off your sides. There's no throwing stuff. I was looking to make sure people, so it's non-contact. We try to be polite, you know, that kind of helps a bit. And the other thing that's likely more important than being polite is it's timed. So the timing is the whole big issue here. And I know when Stephen, my doppelganger, did it, he used to give people the hook. So I've decided to do something different, and I call it the trap door. So I will give them a 5-second warning, and if they don't comply, I have a trap door. And so for those occupational health and safety people, don't worry, we have a foam pit underneath. But it just to keep people a little bit on edge that we mean it when we say the time and the timing. And it's harder than you think. So why are we talking about this topic? I mean, you all know why we are. But again, as someone who felt she should do a bit of homework around that, I turned to my friends at High to see, so what are they thinking about? And they're thinking about, actually, the horse has left the barn, it's down the road, and now what are you folks doing? So it's terrifically timely around that. They had some interesting stats about the take-up of TikTok, the take-up of Facebook, and this is so exponentially more gigantic than that, it's hard to believe. They said since January there's been 100 million new subscribers. So this is sort of, not mine, but your future, all of you. So I think without further ado, the other thing that we're going to be doing before we begin the formal debate is have you vote. There's a QR code, and somebody said it'll be right behind me there, so there you go, on your phones, because what we'll be looking at is, in this minute in time, before we start, how many of you would be for and how many would you be against? So it'll be done in real time. You'll have the opportunity, then at the end, what we're looking for, whoever the quotes winner is whoever has actually shifted those numbers from a point of view that the arguments were. So if you were in this audience, 60% were for, and at the end it's 80% for, that 20% difference might be the difference between winning the debate and not winning the debate. In my day, it was yelling, screaming, clapping, and throwing things. So I think this is a much more intellectual way of doing it. So I think I'll just give it a minute to make sure that people are have a chance to vote. Ooh, everybody's seriously voting. We also used AI to determine who goes first, and some of you be familiar with rock, scissors, and paper, and so Shannon got the vote, and I don't know even how that works, but apparently there's some science to it, and since this is a evidence-driven organization. So I'm just a bit tense about the clock here, my friend Andrew, so if it's all about time, I need to make sure the clock's going. So there you go. There are the sort of real-time. Ooh, it's pretty. So you guys are going to have your work cut out for you because it's. Bring it on. Yeah, bring it on. Yeah. Okay, so Shannon, I think we're going to start with you. You have 2.5 minutes, and I'll give you the high sign at about, I don't know, when you got about 15 seconds left. Okay. So over to you.
Well, thank you, esteemed moderator, panel members, and colleagues. In the face of this unprecedented global health staffing crisis, we stand at a crossroads. Our healthcare system is strained, our frontline workers are exhausted, and patient care is hanging by a balance. It is within this critical juncture that we must recognize the transformative potential of artificial intelligence. Let's consider 3 things it can do. 1, unleash efficiency and improve the provider work experience. Burnout among health professionals has reached alarming levels, exacerbated by the pandemic. AI can step in as a silent ally to lighten the load. When doctors, nurses are freed from administrative burden, they can get back to doing what they do best, patient care. Proof of concepts are being run across nearly all the health authorities and in primary care, looking at how AI can be used to generate discharge summaries, SOAP notes. You're going to hear some of the results from my colleague. 2, AI can empower patients and improve access to care. AI is being used to support patients with care information, care navigation. For the last 3 years, we've used AI to support patient wayfinding around the COVID vaccine with a chatbot that we trained on the government website, significantly reducing the number of call agents required to answer the phone. This has been expanded to all public health on the BC CDC website, and we've recently been using it for patients to help navigate our cancer care system. This digital assistant in cancer care is responding to patients' inquiries, helping to navigate them, and then it redirects complex inquiries to their appropriate place when personalized assistance is needed. 3, AI can enable improved health system decision-making and health system planning. The sheer volume of health data is overwhelming, and this is actually where AI does really, really well. It predicts patterns, disease outbreaks, supports in resource planning. In the battle against COVID-19, AI models were instrumental in tracking and predicting spread. It also can help us in administrative areas. Lynn, can you imagine if we use generative AI to standardize our job descriptions in healthcare? Or how I use Copilot to write my script today? So we do have to be smart. We have to tread carefully. Privacy, security, transparency in AI algorithms, it's paramount. You're going to hear those arguments from my colleagues against AI over there, but that's not a reason to turn from it. It's a reason to plan for it.
Thank you, Shannon. Well done. And you've got 14 seconds to spare. So you set a high bar. But no pressure, Deepak. Over to you, my friend.
I'm going to take your 15 seconds. Look, guys, I'm a practicing physician, and I want to introduce you to the concept of haptic medicine or haptic healthcare. Haptic means touch, and touch is that uniquely human characteristic that we all have. I mean, you can rub your face like this and feel how beautiful it feels. Mine's a bit stubbly, but it's all good, you know? And you know what that means. But how about if you rub your face on this thing? Not so good, eh? Your hand on, nah, that doesn't work. How about, keyboard. You could try the keyboard. How does that feel? It doesn't, right? This is healthcare, and healthcare is about people. And healthcare is about establishing a connection with your patient and the entire team. AI doesn't solve that. It is not the key, remember this, the key to solving our HR crisis. The key to solving our HR crisis is people and spending time. I teach pediatric radiology, and I teach the residents all the time. I said, hey guys, how would you talk to a patient? And they say, well, I don't know, I just kind of walk up to them and talk to them. I said, well, no, you don't do that. If you want to talk to a kid, you do this, right? You get down to their level and you talk to them face to face. You establish a connection. I would argue that some of the technologies that we've developed today remove that connection. The very haptic interface that we use to interact with our computers puts a computer between you and the patient. How is that establishing a connection? It really doesn't at all. And AI technologies are now evolving at a pace that is so rapid that the capability of us to be able to incorporate those in a sensible way, in a mature and evolutionary way for human behavior, is really quite difficult. We are very limited in doing that. We have IT systems that are in the dark ages, number one, and we have people, patients, demanding connections with providers. They don't want more computers in the way. They want to talk to the nurse. They want to talk to the healthcare provider. They want to establish that connection, and then they want to maintain that connection. So my argument is that AI is not the key to the human resource crisis, that actually the key to the human resource crisis is people.
Thank you. No pressure, Sam. Yeah, no pressure, Sam.
Nice. Thanks, everyone, for being here and for having me. So if you talk to the average Canadian citizen or pretty much anybody about healthcare and you say, do you think it's getting better? Say no. Would you say you're hopeful about the future when it comes to the provision of care? Probably not. Most of us in this room work in healthcare. Do we feel it's getting better compared to 10, 20 years ago? Why is that? And so if you look at it, a quarter of Canadians don't have a family doc. That's a problem. Wait times to see a specialist are 6 months, a year. That's a problem. ORs are getting canceled because we don't have enough nurses and folks to staff them. That's a disaster. Yet you have patients waiting, saying, hey, I got a bum knee, I got a broken hip, I can't go to work, I can't walk, but we can't take care of them. We're failing as a society when it comes to our provision of healthcare. And it's not just Canada, it's fairly ubiquitous. But how does that make any sense? Because if you look at most other industries, they've gotten more productive with technology, except for us. And yeah, my opponents may say that technology has failed us, and in some sense, it has. But we're at that precipice where we need more help. We don't have more nurses waiting to help us. We don't have more doctors waiting to come join our clinics and hospitals. If we had the people, sure, you can make that argument, but we don't. And our logistical processes are so beyond broken. And what will fix it is better technology. And when you talk about AI, what does that mean, right? It's nomenclature that's important. How do we define this? This is not replacing people. This is a co-pilot. This is an assistant. This is a helper. It's the computer in Star Trek. It saves you time in terms of doing menial tasks. A lot of what AI does, when you actually look at the technology and what it can do, is actually quite friendly and quite incredible, and it'll help us with those problems around resources. And if you look at it from our clinics right now, get faxes still. Can you imagine? It's 2024. If somebody had told me 20 years ago when I got into medicine, still be using fax machines, that's crazy. Literally, our clinics employ some poor person who hates their life, and they go to the fax machine, and they get something, they scan it, they shred it, they put it in the system, and they do that all day. Our bigger clinics employ 3-4 people to do this. And then you have some poor other person who sits there and types in, okay, hypertension, diabetes. It's crazy. AI can do this, and it already has. I work with Aria Health, which is a company that I co-founded, because of the fact that as a doctor working in the system, I was like, this is broken. We have technology that can automate things, that can streamline things, that can save that person from sitting there and doing that, and use them more wisely. And at the end of the day, it's a no-brainer. To be against something like this is like being against the printing press, like my opponents earlier told me about.
And look at that, right on time. So Michael, over to you. And I just need to say one thing about Michael, how privileged you are that he's here, because his football team, they call it football,
Everton,
is playing right now as we speak. So he'll be right on time because he wants to get going. Okay, so Michael, over to you.
Well, thank you, Lynn, and thank you to Deepak for doing all the touchy-feely stuff so I don't have to do it. So let's be honest. AI makes mistakes. Last week I said, hey, Siri, call Dad. And it said, which dad? And I went, because in my phone, I have my dad, I've got my wife's dad listed as Vivian's dad. So my next question was, hey, Siri, call Mom, because I've got some questions for her. AI cannot replace human expertise and judgment. It can't do non-linear thinking. You go to the operating room, surgery is a bunch of decisions. It's look at something, assess, cut it out, reassess, look at the response, and repeat ad nauseum. AI can't do that. It doesn't do non-linear thinking. We still don't have enough data. We keep talking about the era of big data. AI is lost with limited data. Humans, we can use context, gut feeling, out-of-the-box thinking. AI simply can't do that at this time. Integration of AI. Many of you work in hospitals here. We're already overburdened. With Cerner, I now have 3 nurses in my endoscopy suite in the room, whereas before I had 1. So AI has actually created an HR crisis. AI is overhyped, and it's not the first time. Don't believe the hype. IBM Watson was the great savior. Great at Jeopardy, lousy at medicine. AI cannot do empathy. As Deepak was showing, it can't hold your hand. It doesn't genuinely worry about the patient. Sincerity cannot be taught to a machine. AI in humans, it's a complementary thing rather than one or the other. In breast cancer screening, it's been shown that AI and a doctor outperforms AI alone and the doctor alone. So we should be thinking about these things together. That's not going to solve the crisis in HR. Legal issues. I have not yet had one person give me a straight answer to who is responsible when AI messes up, because it will and it does. No one has ever given a clear answer to that. It's always an obfuscated answer. Over-reliance on AI. This is a significant problem in healthcare. It has implications for education and training and de-skilling when physicians and healthcare professionals rely totally or significantly on AI. There's a significant concern about de-skilling. Shannon talked about exacerbating, or rather improving the access of care. And of course, we want more and more people to have the appropriate access to care. AI can actually exacerbate that by marginalizing ethnic groups if it's trained on the wrong data. Too much, too quick. We need a balanced approach. And if you don't believe me, just last week, Sarah came out from the WHO. That's the Smart AI Resources System for Health. It is making so many hallucinations, and this is just 1 week ago, with lots of incorrect answers. So in 2024, we're still not there. Thank you.
Thank you. Thank you. Well done, on time group. Excellent. I won't need to get the trap door out. Picking up on a couple of the things, and I'm going to start with you, Shannon, perhaps, because Deepak would say that using AI, you're not going to be able to get on your hands and knees anymore. So I wondered what your response to that, the humanity piece, but I really liked the illustration.
Ready to respond to that.
Okay.
I've been waiting since you said it, Deepak. This is where AI can actually help. AI doesn't replace humans, it augments. It augments our work. Together, we work together and we improve humanity and that human touch. AI is not old school technology where I have to add more technology and more equipment and more computers in front of me that's putting me as a barrier in front of my patient. It's putting it in my pocket. It's listening to me as I'm talking, as I'm looking at you in the eyes and building that human connection. That's what AI can do for us to help build that touch.
Okay, Deepak, over to you. I mean, there's point counterpoint. So what's?
Thank you.
Oh.
Yes, you are right. Right. I can't argue that. I can only argue one point, and that is that device is still in your pocket, right? And it's making way more work. Right? It's actually increasing the burden on all of us here that are providing services in the health system. You heard it, right? We went live at Epic in Alberta, and I remember in the OR losing 30% of our volume of cases because of the overhead required to actually input the data, right? Unbelievable. So I think some of these technological steps are actually substantially hindering our ability to scale our health system and to provide those services. I have to agree with you that I think there are some areas where AI can help, right? But it's not the key to solving our human resource crisis. And right now, the question is, artificial intelligence is the key to resolving it. I don't think it's the key. I still think the people are the key.
Thanks. Thank you. Any response to that before we get into one of Michael's points?
Yeah, Deepak invited me to a book burning earlier. I was like, I don't know if I want to come to this. So here's the thing about technology. There's all kinds. Some is bad, some is really great. And so look at ourselves in our lives. You have iterative technology as well. When cell phones came out, they were the size of a brick. Nobody said, let's not use them. Most people didn't, but we kept making it better. And then the flip phone came around, and texting on a flip phone was pretty painful if you wanted a queue, right? But people still did it, and eventually it got better, right? That's the thing about technology. It's not all created equal. Some tech that we use in healthcare is not very well made, and I've been the biggest critic of that from day one. But it can get better. And over time, we shouldn't abandon it just because it's not perfect right off the bat. In fact, sometimes better is the enemy of good.
Thank you. One of the things that Michael said, though, I'd be interested in your comments. I think I heard you say it actually using AI takes twice as much of the clinician's time, and I may have misinterpreted that. But I was trying to reconcile then how you folks would think that's the key to the HHR, if you need actually technology and a person.
So essentially, let's put it this way. It's a co-pilot. It's an ancillary. It's a tool. So you mentioned it makes you less efficient. Yeah. Let me give you an example that currently happens, that exists with the technology. So the worst part of your day as a doctor is usually writing your note. We used to write it on paper, and then we used to type it. And now, if we're lucky, we have a template that we click through and type or dictate. And Fessor is not perfect. In fact, it's not that great, depending on if you have a bit of an accent or if you're in a busy room. With AI, you actually look at it and you can have a conversation with your patient, focus on the patient so you're not typing away and being distracted. So actually it's improving your interaction with the patient while it listens. And once you're done, you click a button and it creates your note within 3 to 5 seconds. I know this because I do this in clinic today and many of my colleagues do. If you actually see this technology, it looks like magic, but it exists and it'll save you so much time. Your current note, depending on how you do it, takes 2 to 5 minutes, maybe more, depending on what kind of specialty you have. Imagine 2 to 5 to 10 minutes turned into 5 seconds. It's pretty good. It's pretty efficient.
Hello? I'm just glad Lynn didn't ask me about getting on my hands and knees.
That's next.
But, so I take your point, but, and the key is the but here, that automated report that frees us up, that gets us, more time apparently, it's based on the input. So if the the metrics that we're trying to put into a report, for example, are not based on robust data, proper algorithms, etc., you're going to exacerbate the inaccuracy problem by relying on it in your reporting. You give it a quick glance and say, yes, next. I'll give you a real-world example. In BC today, we have some AI technologies being used in hospital, in healthcare. I'll talk about GI, my field. Things to improve polyp detection, precancerous lesions for colon cancer. Several studies showed that the polyp detection rate may be increased by 8, 10, 12%. That's fantastic, because if you decrease polyp rate by, if you increase it by 1%, you'll decrease colon cancer mortality by 3%. In real-world studies, in the last 12 months, it's been shown to have either a neutral benefit, in other words, none, or in some studies, it's actually been shown to hinder performance. And then when the doctor is working with an AI technology, it puts them off. It makes them, who knows what, but they get distracted. And there have been some studies recently saying AI makes performance. So if you're using those metrics to go into your automated report, we all hate writing stuff, then your report, you're compounding the issue time and time and time again, all along the chain.
Thank you. So when you're the moderator, you get to ask anything you want. So one of the questions I have is, we've focused a lot on acute care, and hospitals are important. There's a great big community out there that's a community. And so how do you see AI helping in the biggest sector actually across the healthcare system that has exactly the same HHR challenges and doesn't have some of the bells and whistles perhaps at acute care? So I don't know, go ahead, Shannon.
Happy to start here. I do want to go back to a few of the points. Yeah. People are important. I'll relate it to this and how we can use AI in more rural and remote areas and out of acute. People are absolutely important to make AI work. What we need to think about is the types of the roles and the people that we do need to make this work. We need to think about the data scientists. We need to think about the training that we're providing around these AI tools. We need to think about the review around these AI algorithms, and we need to plan and review our policies and processes to make it happen. What that means is we need to look at those types of roles and support with supplementing where we have HHR challenges, like getting doctors into rural and remote areas of our province. So instead of focusing on getting more doctors that we know we're having a hard time getting there, how do we give them a point-of-care ultrasound device with AI embedded in it, or tools that can help them to treat patients on the spot, virtual other physicians in, so that we're not so we're helping to give patients the access that they need.
Thank you. Go ahead, please.
But getting, and I agree with that, but getting access, getting more assistance to the marginalized communities, to marginalized ethnic groups, etc., relies on having, again, accurate input data and algorithms. And there are several examples. Most current algorithms that you are all familiar with are trained on fairly homogeneous sets of data. They do not translate well into real global practice. And in fact, if you rely too much on that, you may actually make the inequity of access worse. A study in the New England Journal a couple of years ago looking at the healthcare resource needs in the States in Caucasian and African American populations. And because AI got it wrong and it underestimated the prevalence of disease in African Americans, it actually devoted less resources to them than the white population. So if you don't have robust models, and we're not there in 2024, we are not in the true era of big data. So yes, AI shows great promise, but it is not the key today, or I would say for the next several years, to solve the HR crisis.
So you bring up an interesting point also, though, and I'll put it to the two of you, is in those algorithms, it's certainly exactly, the bias is coming out. There was a program on not that long ago that talked about the bias in looking at people's resume, and they plunked in, algorithms, and so clearly someone like me, even though I'm vintage, would actually have been spit out. So how do you actually mitigate that around these programs when we're talking about real people, real clients, real patients?
Well, if I can maybe add to that, and to your point, is that it's funny because we often operate out of fear when we make decision making. And then you get one study that comes out and there may be a sampling bias that's looking at a very narrow field. The real world is very different from what we can create in a study often. And it's amazing how often these studies are wrong. We get a medication that says, hey, this is going to be game changing. 2 years later, we're like, oh, it's giving everybody a stroke. We've seen this time and time again, right? 10 years ago, I was involved in a telehealth company where we democratized, through technology, access to healthcare. The college, the ministry, the government, everybody said, this is terrible. Look at what's happening. This is bad. A short 6 years later, if it wasn't for telehealth, how would we have provided care during COVID, during the pandemic? We were so wrong about telehealth. We went after people who created telehealth. We tried to shut down telehealth. In many provinces in this country, they still don't have fee codes for it, right? But could you imagine, in this day and age, such a short time later, not using it? And it's the same thing with this as a technology. It's an ancillary. It helps you out. We'll see how it is in the real world. And the benefits are above and beyond.
Deepak, were you going to?
I'm being very patient. I'm being very patient. And
I thought maybe you were going to get down on your
before I
hands
get
and
on
knees
my
again.
hands and knees again. So let's talk about human resources. It's called HR, human resources, right? The fact is that right now we're looking at this world, and I agree with a lot of the things that you're saying. AI is just at its nascent stages. I'm a founder of an AI company, for crying out loud, right?
Yeah.
Like, I recognize that's important. But I have to say that I also practice pediatrics, and when I see what the human resource crisis is in this country and actually beyond this country, it really is not something that's going to be solved by AI. It's going to be solved by improving the overall efficiency of our systems. And that is a lot to do with the way in which patients access the system. It's a lot to do in the way in which patients are actually processed through a system. And adding all these levels of processing just actually increases the time that patients have to actually get care, and more importantly, increases the strain on the providers providing that care. And I think if you look at the human resource crisis right now, a lot of it is people just getting burned out. Look, I mean, I was doing call 1 and 2, right? Every week I'd be on one week, off another week, on a week, off a week, just because you can't find people to work. And it's just completely exhausting. I don't know how a machine learning algorithm is going to solve that problem.
Michael, did you want to add something?
I've got a quick question. Anybody know the latest Everton Liverpool score? It was 1-0 at half-time to my team. I think I'd like to bring it back to diagnostics. A lot of what we're talking about, let's say in the pathology service, we want to lessen the burden on the human pathologist and the tech team. Very recently, and I know this sounds like cherry picking, but this is very recent work in helping a doctor find cancer in a slide, in a pathology slide in breast cancer. And AI algorithms, so-called mature algorithms were developed. And guess what? The machine was great. And when they pulled the network apart to see what the machine was making the decision on, it was making it on the ink mark that the pathologist had put on because they had read it before and said that's where the cancer is. The machine was finding the ink mark and recognizing that was important. It wasn't seeing the features. Now, that's an extreme example, but medical AI is littered with those examples right now. It is getting better. It will get better. But we're debating the key here. It's not going to solve our HR crisis today because it is simply not reliable.
You win. I think the point that was made about virtual health and telehealth, and I think there's been quite a shift in thinking around that. One of the things Christina said this morning is that our patient partners are here in this room. So what is your sense of what people, not us, people want out of AI and their human resources? Have you got some thinking around that? It's a tough one, but that's the whole point of being here is those people, our communities, what do they want?
I think people will be open to it. I mean, people are using AI in their daily lives. They're going to expect to see that how we're integrated into our healthcare system. They're going to expect to know how it's being used. I think we really need to think about transparency to patients and citizens. We need to think about what informed consent around AI looks like. But if you can get access to information from a digital assistant around your prepping for your cancer surgery, are you going to go on to that, or are you going to continue to call the help desk and wait, or not find that information? We Google things today. AI can help direct us to a non-Google trusted clinical source. Of course, yes, there's work to do to ensure that the data put in is constantly reviewed and constantly trained and constantly improved upon. But how can we start to ensure that we're giving our citizens more accurate, reliable sources of information through these AI tools? I think they'd be very open.
And to your point, Michael, and what you were saying before is that it's making an argument that just because something's perfect, it shouldn't exist or shouldn't be used is an argument that I think is invalid. If you take a look at, like Google you mentioned, Google's not perfect. There's a lot of bad Google searches. There's a lot of stuff on the internet that is inaccurate. But would you take that away from patients? Would you take away the ability to educate yourself? Would you take the ability away through AI of saying, hey, there's a rash I'm worried about. Let's take a look. Is this melanoma? Don't worry about it. How many patients say, I don't want to go see the doctor, or I'm going to have to wait forever? Imagine if you can just take a picture and says, actually, this may be melanoma, go see a doctor right now. Right? Think about the lives that you could save. When you take a look at resources, we don't have enough radiologists or dermatologists or pathologists. If you're in a remote community, I used to go up to Yellowknife every couple of weeks, great community, underserviced. Can you imagine what something like AI would have done for us up there in terms of access and help? A lot of the time you say, we have nobody to read these echocardiograms. Well, if you have nobody, I'll take an AI who may make mistakes over nobody, right? It's that pragmatism that we need to, espouse when we look at this kind of technology.
Sam and Shannon are focusing on the little acorn within the big forest, the telehealth issue, telemedicine, the advent of telehealth. Fantastic, great, but it's not solving what most of you see when you walk into a hospital or you walk into a GP clinic, which is the masses of humans who are overworked and overburdened, and the AI solutions are not yet there. And our government agrees with us. They put out in Ontario, I think, a $2 billion package there recently for technology advancement, and $12 million of that was focused on AI. So clearly, they don't think, and hopefully experts within this don't think that we're ready yet for mainstream AI. So we'll all buy the telemedicine argument, but if that's what you're basing your debate on today, it's not the key. So don't be inappropriately driven towards that side of the spectrum from one little pimple that they're trying to squeeze out.
So do you have something to say about being an acorn?
I just want to say in Canada, we have some of the best tech innovators, and compared to others, we can't deny some of the great investments and companies that are supporting us in the advancement here. We have to embrace that. We have to figure out ways to partner with it, or we will be left behind.
That being said, we don't do a good enough job of supporting innovators. I think most of us here work tirelessly, not for money, but because we actually care. And when you're trying to do a startup, when you're trying to build these things, and to your point, and listen, if anything, we don't support innovation enough. We aren't entrepreneurial enough. If anything, most of my career in medicine has been, private sector. They're the worst, right? Not really. Depends. Everything's different. There's so much nuance, right? We're doing a lot of great work that's going to be transformational. And I think Michael's point is to try to belittle that as an acorn, but the reality is quite the opposite. It's exactly like any kind of technology that comes in. How are we defining this? What kind of car are you driving? Very different. What kind of computer are you using? This AI technology, which one are you looking at and in which functionality? If you're running a clinic and somebody said, hey, listen, you can't find enough MOAs, or you have 2 to 3 MOAs per person, which I think anybody running a clinic has seen this, and your overhead's so high and you can't, you either don't have people or your overhead's so high you can't afford to keep the doors open.
I'm going to get the trap door out any second now. This red light's giving me a seizure, so I'm just need to wind it up. Thank you.
So at the end of the day, this is something that if you did, even today, utilize it, it would save you so much and allow you to provide more and better care.
Thank you. So I think we should give a big round of applause for the first round. Well done, everyone. Now you each get a minute, not a minute and 5 seconds, to actually sort of wrap up your perspective around this, particularly given what you've heard from each other. So Shannon, we'll start with you again.
Okay, so as we stand at this crossroads, AI emerges not as a rival, but as an ally, a force that can multiply, amplify our humanity, not diminish it. So let's think about how it can really improve that health experience, the health worker experience. With increased efficiency comes increased staff retention. AI ensures that experienced professionals remain committed to their calling rather than prematurely exiting the workforce. We are going to attract new talent to this workforce if we show them that we're integrated with the latest technologies and AI as supporting tools for them. As we talked about, it can also empower patients, improve access to care, and support our health system planning. So let's not choose sides, human or artificial. Let's harmonize their strengths as a force multiplier. We are doing some pretty cool things in BC, and we can lead the way here.
Excellent, thank you. So Deepak, over to you. I'm afraid what you're going to do this time.
Backward flips.
Backward
off the stage,
somersault.
yeah. Look, the practice of healthcare is an intensely interpersonal balance of art, science, and spirit. And for every single one of you here that's had the opportunity to work with people, right? That's the most rewarding part of what we do. We work with patients, we work with our colleagues, and we love it. I think that, I could get up here and say, train more nurses, right? That's probably the right answer. And that's what we need to do. We need to start focusing on how we have an aging population. I don't think that AI is going to go away. I think it's going to have an increasing role, but I don't think it's the key. And that's the point, right? I think it's just one component of a much bigger picture that involves hiring more people, providing better work environments, making sure that the processes are smooth and efficient, and ultimately, I'll get down on my hands and knees and say, vote for us.
Vote for us. Sam.
Growing and aging population. We don't have enough doctors and nurses. The ones that we do have are leaving the profession in droves due to burnout and looking for opportunity elsewhere. Our hospitals are falling apart, wait times are higher than they've ever been. The only solution available to us, although imperfect, is to have an ancillary in the form of technology like AI that helps streamline things, bring down costs, allow you to do more work with less. And ultimately, I think it's the only way we can really save healthcare.
Thank you. And Michael.
Okay, AI is really expensive. So last time I checked, there were no reimbursement codes in this country for AI or anything mainstream. There are 2 or 3 preliminary codes in the US. So who's paying for it? We've got a long way to go with that. You look at the regulatory bodies in Europe and the FDA in the States, they are constantly, last week, changing the guidelines and moving the barriers to adoption of healthcare. So they haven't decided yet. We have not yet convinced patients. I don't know a patient who would tell me, I'll happily take a machine, make an answer for my cancer diagnosis than you, Dr. Byrne. Well, actually, let's not get into that. I wear a Whoop, right? A wearable, heart rate variability, all that kind of stuff. Yesterday, it told me I was in the stress zone for 4 minutes. I would sign up for that every day of the bloody week. Because I was in the stress zone for about 14 hours yesterday. But the Whoop said 4 minutes. That's AI. And had the trapdoor been working before and driven by AI, Lynn, it would have pulled it 2 minutes earlier on Sam, because he went over.
Very cheeky, very cheeky. You just want to know who's winning the game. I know that.
Do you?
Yeah. No, I don't know that. So that's a wrap. I think we have heard a lot of information here. I have to say, what I've come away with a bit is necessary but not sufficient, and we'll never forget Deepak being on his hands and knees. And then I think it sort of goes full circle to something that Christine and Devin said this morning when they were talking about Doug, this whole humanity and healthcare. And I'm not hearing any side of this argument not saying how important that is. And if anything, when Shannon was giving her examples, I think she was very quick to point out, we're not talking about getting rid of human beings. But I think that one of the things perhaps that was kind of interesting is the key to solving our HHR crisis. What I'm hearing from both sides of the panel, it's necessary but not sufficient. And there's lots of things to think. The one piece I wanted to pull up that Shannon had mentioned was privacy and confidentiality and likely ethics. So I think there's a whole body of work perhaps, that is either being done or needs to be done around that. So we've come to the end of the debate, and you guys did a fabulous job. And bit disappointing you weren't throwing things at each other, but it's okay. It's nice to be polite Canadians. With one exception. So what we're going to do now is re-poll. And if you recall in the beginning, you all put in, your vote around whether you were for or against. And the whole point at this point is, so how much has that changed? So if you were, I think we were something like 54 something, 4 and 45. So where are you now after hearing our debaters? So we'll give that. Yeah, that's right. You can be bribed. Shannon has some incentives here. I never told this side that you could actually, give treats to the crowd.
I'm surprised nobody mentioned Terminator on that.
Yeah, I know. So it's interesting. I mean, certainly the against. So well done, the two of you that are founders of AI companies. I don't know what that says, but it's not for me to say. But can I
tell the truth?
Yes, you can tell the truth now. There's a reason we say that we assign the sides, because do you think Deepak and Michael would have said, "I know what I want to do. I actually want to argue against my livelihood and the work that I do." So well done, and I'm not sure the positive is any easier, to be quite honest with you, certainly around the humanity piece. But if you look at this, it's still quite close, but the biggest movement has been in the against, so I don't know whether that makes the two of you now looking for another job, or whether we're good now. So I think this has been a very interesting debate. I also think that you could likely do this, Christina, every single solitary conference you have, because this is the world. Everybody's out there. Even me, I can do chat GPT. I know you're impressed by that. Even though the introduction was a little bit off around that. So we want to thank you all for your attention. I think that they really, in the olden days when you could yell and scream and whistle and that, I think that likely is appropriate because they've done actually such a fabulous, fabulous job. So thank you.